Recording in progress.
Good morning, and I would like to welcome everybody, also friends and family who came, I think, all the way from India. Very welcome. We're going to have today the defense of Mr. Naren Shetty. And hereby I open officially this academic ceremony in which Mr. Naren Shetty will defend his academic thesis entitled Analyzing Optical Performance of Natural and Intraocular Lenses in Asian Indian Eyes. May I invite you to present a summary of your study and the conclusion of your thesis in the next 50 minutes. And I'd like to give you the word.
Thank you so much, sir. Good morning, dear Prorector, honorable members of the Corona, family and friends. Now, in the past, patients used to have a lot of demands, but our current generation of patients are so much more constrained. They just want one thing, they just want one word, they want everything. Now, when we look at the journey of being spectacle independent, at different age points, we face different challenges. And a natural or intraocular lens plays a pretty vital role. So let's look at the first part that is in the 20s and 30s. Before that, what is normal vision? Normal vision is when the light, what enters the eye, it falls perfectly on the retina and the person sees really well. We call it normal vision. But if it doesn't fall on the retina or the nerve of the eye perfectly, that's when we have refractive error, or we say we have power in the eyes. Now, if you look at this data, by 2050, 50% of the world's population is going to have refractive error or power in their eyes. And as you know, over the years, the number of refractive surgeries being done has drastically increased. Now, if you see this brown or the black part of the eye, in front of that, we have a glass-like structure. This is called the cornea. On top of this, we do all these laser surgeries. There are different kinds of surgeries. First, let's look at what happens in trans-PRK. Basically, the laser hits directly on the cornea, molds it, corrects the power. Then in LASIK surgery, the flap is created, laser is done, then the flap is placed back. And in SMILE surgery, there is no flap created at all. The laser hits and dissects a central saucer-shaped piece, creates a small opening in the side, and through this hole, we remove the lenticule and we are good to go. But what really happens to these eyes post-surgery in terms of accommodation or visual quality as compared to age-matched normal individuals? So we looked at this particular aspect. If you look at the vision, the LASIK and the SMILE were comparable to the normal eyes at all targets, but the trans-PRK eyes were marginally inferior. When you look at the residual power, the spherical part, the LASIK again was comparable to the normal, followed by SMILE and trans-PRK. But in the cylindrical power, the LASIK again was closest to the normal, followed by trans-PRK, and the SMILE did the worst among the three. Now, when we come to the accommodation part, basically it is the process of focusing nearby. The LASIK was the closest to normal, followed by SMILE and trans-PRK. And we move on to the next group, that is the presbyopic group. Now, a natural lens has the ability to change shape. Because it changes shape, we are able to focus nearby things. But by the age of 40, 45, in the presbyopic age, we lose this ability because of the hardness of the lens, because of which we wear reading glasses. So we thought, can we actually help these patients to see better for near by using spherical aberration? But what is this spherical aberration? Basically, it is a concept where when the light passes through the lens, it doesn't focus to a single point. Now, for instance, the peripheral rays, if it focuses to a point closer to the lens than the central rays, then we call it as a positive spherical aberration, which happens on the cornea. And if the peripheral rays focus away from the lens as compared to the central rays, we call it the negative spherical aberration, which happens with a natural lens. So for this experiment, what we did is we used a machine called a visual adaptive optics. Other than analyzing what is happening in the eye, it can also alter the spherical aberration so that the patient can appreciate real time how his vision is changing. So what we found in this particular study was the uncorrected vision of near and intermediate of diabetic presbyopic eyes was better than the normal presbyopic patients. That is very interesting, even though their uncorrected vision for distance was the same between the two groups. What we also showed was by using this spherical aberration, we significantly improved their near and intermediate vision without compromising the distance. Now, coming to the next age group, the older age group. So at old age, we face a problem called as cataract. But what is this cataract? See, our natural lens is like a glass. It's like a clear substance. And over the years, as we age, it loses its transparency, becomes white, and we call it cataract. Now, patients with cataract not just want quantity of vision, they want the best possible and beyond quality vision. And to achieve this, there are several steps we need to take. First is to select the right IOL. For this, your biometric machine should be really good. At that point, Antirion was a new machine, and we compared with the lnStar 900 and the IOL Master 700. Now, when you look at the comparison, basically all the machines had excellent repeatability, and among the parameters measured, there's a parameter called as white-to-wide. Basically, it is the edge-to-edge measurement of the cornea. This the IOL Master 700 didn't do that well in this particular measurement. And coming to the lnStar 900, the repeatability was excellent, and also the variability was the lowest. So basically what we showed is all the three machines had excellent performance, performed really good, and the lnStar 900 had a slight edge in terms of performance compared to the others. Now, by just selecting the right IOL, is our job done? Not really. We have to make sure that even in the OT or the surgery, we need to do it perfectly. So what happens in cataract surgery? This cataract is inside an eye bag, right? The front part of the eye bag, we make a small hole, remove the cataract, and put a fresh lens inside the same bag. Now, there are some lenses which need to be at a particular axis. Okay, so these are called toric lenses. And these toric lenses, post-surgery, there is a risk of it rotating. And this usually happens during the 1 hour post-operative period. So this happens because of less contact between the IOL and the bag. So we thought, can we actually improve the contact between the lens and the bag? So we did certain experiments. So what we did was we thought, okay, let's see if we orient the lens differently, one vertical and one horizontal, and see how the contact changes. So what we did here was remove the cataract, put the lens into the eye, removed everything else, and maintain the physiological pressure of the eye, and took an image with the intraoperative OCT. Okay. Now, as you see, after the image is taken, in the same eye, I rotate the position into vertical position. Again, I take the image with the intraoperative OCT. Now, this is possible only if you have an intraoperative OCT. Now, let's look at the image. Now, if you look at this horizontally, when it is oriented, you can see the space between the lens and the bag. But when you orient it vertically, the space is reduced. So that means there is better contact between the lens and the bag when you orient it vertically. So we thought, okay, what else can we do to improve the contact? So what if we use a CTR? Basically, it is a ring which is placed in the eye bag, and this expands the bag and brings the anterior and posterior capsule together. So to do this very similarly, we remove the cataract, put the lens in the bag, and once it's done, we took the image with the intraoperative OCT. Now, we added this ring without adding anything else in the eye, under irrigation itself, and then again imaged it with the intraoperative OCT. Now let's look at the images. Now, if you look at the before image, this was the space between the IOL and the bag, but after we implanted the ring, you can see the space, how it's reduced. It's much lesser, right? So it has improved the contact between the IOL bag after we implanted the CTR, and what was even more beautiful was, as the size of this ring changed, there was better contact between the lens and the bag. So how does these two studies really help us in the future? So we showed that with the help of the intraoperative OCT, we can actually assess whether there's good contact or not, so that you can assess the risk of it rotating post-surgery. That way you can improve the post-operative outcomes. And also we can ask the companies to design the toric lens such that they are oriented vertically for better contact. And also you can implant the ring in the back in toric lenses for better contact. Now coming to these lenses, these are called as enhanced monofocal or non-diffractive EDOF lenses. By using these lenses, you have good distance vision and good intermediate vision, but not that great near vision. So we thought, can we actually improve the performance, or basically how they read? Can we improve their performance? So we thought we use spherical aberrations in these patients. So what we did was, but before I go into the experiment, let me explain this particular chart. Okay, this is called the defocus curve. Basically what it says is how the vision of the eye is at different distances, all right? So the blue line is the defocus curve. So if you see this red line, every time the blue line touches or comes closer to the red line, that means if it touches the red line, that means it has normal vision. And this 0 indicates the distance area. The 1.5 indicates intermediate area. 2.5 indicates the near area. Now among the three, which is better? Yes, the distance is touching and going beyond, so the distance is really good vision. But among the intermediate and near, because the near is slightly closer to the red line, so that is, the near is better than the intermediate. So let's come back to the experiment now. You can see the pink line of defocus curve, right? So that is the line where we have induced post-induction of the spherical aberration. And if you see, the distance has not reduced, it's still maintained, and it is good quality, but the near has improved. So we showed that there is still potential, some amount of potential to improve the near vision in these lenses too. Now we thought we needed to look at a different, different way how we can improve the near vision. So now when we become older, like I mentioned earlier, we wear reading glasses to see near. This reading glasses has spherical power. Now we cataract surgeons also use this spherical power to improve near vision. So what happens when we use a regular lens, a monofocal lens? The distance is very clear for the patient, but the near is compromised. So what we sometimes do is when we operate the other eye, we use the spherical power so that the patient sees near, but the issue with this is the distance is compromised. So we thought, can we do something to improve the near without compromising the distance? So we thought, let's use cylindrical power instead of spherical power. So we did the experiment. Again, you can see the defocus curve. The blue line is the new cylindrical power used. The yellow line is the old spherical power used. Now again, by using both spherical and cylinder, intermediate and near both improved, fantastic. But what is more important is the distance. Here you can see the distance has not dropped in the new cylindrical power, but the distance has dropped in the spherical power. So basically by using the right amount of spherical aberration and the cylindrical power, we showed that we can actually improve the near and intermediate without compromising the distance. Now, by choosing the right IOL and by doing the perfect surgery, everything's gone perfect, but still the patient's seeing well. I'm not well. What are we missing? Actually, we are missing the retina or the nerve of the eye. This plays a very vital role in terms of visual outcomes. And there are many studies which show that there's no change in the retina post-cataract surgery, but there are some studies which show there is change in retina post-cataract surgery. So to solve this issue, we custom built a polarized sensitive OCT in collaboration of University of Vienna. Basically, with this new PS OCT, we were able to achieve a resolution 3 to 10 times better resolution than any other OCT in the market. Just to give a small example, this is a normal OCT. If you see this bright line with the bump in the center, it's a very important layer. It's called a photoreceptor layer. Now with the PS OCT, you see the dark blue spots, that is the same layer, okay? Now let's look at a condition where this layer has disappeared. Actually, if you have an OCT like this, the patient should have very bad vision. But the patient has 6/18 vision. Where is the vision coming from? Where is he seeing from? The layer is missing. But with the PS OCT, you can see these bright blue dots that shows that this is the area where the patient is able to see. These are the fine details which you can really appreciate with the PS OCT. So basically, we took this the PSOCT and saw how the retina changes post-cataract surgery. I won't go into details. Basically, there was no significant change in the retina post an uneventful cataract surgery when done by an experienced surgeon. I have to disclose that the surgery for most cases took less than 3 minutes, and we need to do further experiments to see what happens if a trainee or a fellow does it where the tissue is not handled that well. And also, definitely, PSOCT helps us to evaluate subtle retinal changes following a cataract surgery. I'd like to end by saying that I use this particular image as the cover of the book. As highlighted in the presentation, with the right balance, we will always see the light beyond the challenges. And this is true not just in the practical aspects of life, but in the spiritual angle too. I would like to thank all the members of the Corona and my family, my friends, and also my father, who I lost recently. In fact, I'm wearing his tie too. And with all your help and support, I am what I am today. Thank you so much.
Thank you very much. And I must compliment you with your very nice presentation, well illustrated, and with some nice reflections at the end. It's a compliment you have deserved already before we start.
Thanks.
And for audience, and maybe some audience who are online, because it is an online event, we will have 6 opponents today for you to inform you, and 1 opponent will be online, he will be on the screen, and there are 5 opponents who are here this morning in this aula. And before we start, I also would like to introduce the promotion team, which is quite common. And we have 2 members in the promotion team, which are sitting opposite of me. We have Dr. Roy. He is involved with the Department of Ocular Imaging and Artificial Intelligence / ML. I'm not sure what ML is, because I know AI is artificial intelligence. He is from the Naren Shetty Foundation in India, in Bangalore. And I'd like to thank him that he joins us today this long way. In addition, we have the first promoter, is Professor Nuits. He's from the department here in Maastricht, from corneal transplantation and refractive surgery. And I would like to thank both of them that they guided you over the years to really get to this point that you're going to defend your thesis today. Saying this, we're going to start. And like I mentioned before, we have 6 opponents who are going to address some questions to you. And I would like to start with Professor Webers. Professor Webers was the chair of your assessment committee, and he is involved in the department as head of the Department of Ophthalmology, and I would like to give him the first opportunity to discuss with you. Professor Webers.
Thank you, Mr. Prorector. Dear Mr. Candidate, first I would like to congratulate you and your supervising team with your thesis. I think you have proven to be a true and rightful member of the scientific community, although you still have to defend your thesis today. And like all important scientific work, it probably raises more questions than it provides us with answers. So I do have some questions, and mainly about chapters 7 and 8. Those are the chapters that deal with the distance between the posterior capsule and the IOL.
Right.
Okay. And as I understood, if you put in a CTR ring or put the haptics in a vertical position, the distance decreases. Can you explain what happens? Is it that the IOL is moved backwards, or is the capsula moved anteriorly? What is happening at that moment?
Right. Thank you so much, highly esteemed opponent, sir. Thank you for the question. So what really is happening is basically now if we look at our natural lens, it's more thicker than our artificial lens. So our bag is a little more stretched than normal. So when we put a thinner lens into the bag, so it creates the space, so there's a little bit of floppiness of the capsule, and that is initially till the fibrosis set in, so that then it gets attached to the lens. So when we put the CTR, it stretches the bag, and then it makes the bag a little more stiffer. It's like as if we put our hands into the plastic and we stretch it sideways, the bottom comes up. Mm-hmm. So very similarly, but the lens position has not changed.
Sure.
Yes, yes, sir.
Yes, because in the discussion somewhere you said there are 2 main positive effects. One is on the position of a premium IOL, and secondly, to prevent posterior capsular opacification.
Right.
So, do you have any clinical data on how sure are you, for instance, that the lens stays in the correct position? Can you prove it with clinical outcome, for instance, uncorrected visual acuity or whatever?
Yes, excellent question, sir. So basically what we have, for this, in my book, I have not looked at that particular aspect because it wasn't part of the objective, sir. But we are currently have done certain studies where we have looked at before or after implantation of the CTR in terms of centration, in terms of tilt. We are about to publish it, sir. As of now, it looks, everything looks good after implantation of the CTR. It doesn't change any other parameters, including the lens selection. The power also remains the same. So for now, what we have done, sir, is we have worked on normal ranges, but now we have to see on the extreme what happens to very short eyes, long eyes, how things change. We thought we'll do the study in groups.
Mm-hmm.
Yes.
Do you expect, you say somewhere, I think that the CTR ring has to have overlap in the bag.
Right, sir, right.
Yes? Is the position of the overlap relevant?
Yes. So the thing is, sir, it depends on the design of the lens. Design of the CTRs. There are some CTRs, when you take it out of the container, the edges are touching each other. So obviously, when they go inside, there is a chance it might overlap, and that's when things go wrong. But the CTR which we have used, there is a gap. So it has a buffer zone. So if at all it gets compressed and it doesn't overlap, or there's no other disturbance in the bag. So that, I would say, maybe it has an edge in our study as compared to
and
studies.
Look, I have to look at the time. Yes, another question. I think if you look at table 1 on page 117, so that's the CTR chapter, and table 1 on page 132, that's the haptic study. It was my impression that the distance after removing the viscoelastic was larger in the haptic study. Before putting in the tension ring or turning the IOL. Was that because of the different types of IOL?
No, we use the same IOL, sir, for most of it, because the beauty about using intraoperative OCT is we are not seeing different patients or different lenses. We are using the same lens in the same eye and same bag. So that way, you know.
Yes, but sorry, but in chapter 7 and 8, you used different IOLs. I think
yes,
you used the Vivity and the
yes, that's different. Yes, that's
has
different.
that any effect on that distance?
Yes, sir. So in our study, we haven't looked at how different lenses behave. For now, we have selected one specific type for each study, sir, so that there's no variation. But like you mentioned, sir, I think it'll be a good idea to see how every lens changes, because the size, haptic design, the strength, everything is different from different companies and I would say different models. So it'll be a very good idea to have a look how the plate haptics work, how it stretches the bag, and how the contact. Okay. Definitely, sir.
Maybe one last small question. Okay. Do you think it's a cost-effective procedure to put in a CTR? A given clinical outcome, etc. Do you take that into account when you're publishing your outcome studies?
Yes. So the thing is, sir, even if not for the studies, I personally, for all my toric patients, I do implant CTR, because I would say I'm looking at the chance of post-operative rotation is about 2% or 3%, but these are all very premium patients, sir, who are very high demanding, and even though it looks like 2%, but they will talk to so many people, it will affect our 30% of our practice.
So they are willing to pay.
Yes.
Okay, thank you very much for your questions. I'm happy.
Thank you, sir.
Give the word back to the pro-rector.
Thank you very much. The opposition will now be continued by Professor Konen. He is affiliated with the Department of Ophthalmology at the University Hospital in Frankfurt, the so-called Goethe University, and I would like to give him the opportunity to discuss with you. Professor Konen, sorry.
Yes, Dr. Shetty, very nice presentation for your dissertation. I have a couple of questions. Let me start just a follow-up of the study of the questions you just received. Are you aware of the AJO publication, recent publications that they have demonstrated that actually a CTR ring, it was the AJO paper with plate haptic, did not actually increase rotational stability. Actually, it was a contradiction. This was the group of Menapacha was reported in AJO. And could you elaborate a little bit on this? Because I think that, CTR is a little bit controversial topic. I just removed an IOL this morning in the capsule, actually on the retina, which has a CTR. And there is a lot of pressure in the CTR. And you just said that you predominantly put all in your toric lenses CTR. Why is that? Explain this to me.
Thank you so much for the question, highly esteemed opponent, sir. So I think this is a very important point. So there's a lot of, like you said, sir, it's a very controversial topic. Now, one of the beauties of the intraoperative OCT is we can actually see live in which cases does it really improve contact and which cases it doesn't. So it'll be fantastic to do the same studies which have already been published in the same pattern to see after, let's say, if there is an improvement in contact, and then does it really rotate post-surgery or not. It'll be a nice way to look at it, sir, because a lot of times what we have observed coincidentally when we are doing all these studies was, sir, there are some cases even within the normal range, because we are looking at 22 to 24 axial length range. There are some cases when we inject viscoelastics, there is excessive deepening of the chamber. I think each one of us have faced something like that. Those are the cases we have seen, they have a higher risk of the lens rotating. So that is something very difficult to measure preoperatively, because we will appreciate only intraoperatively when we inject viscoelastic or turn on the irrigation. Suddenly there is a deepening, excessive deepening, which normally shouldn't happen in a normal range axial length. And those are the eyes, if we exclude in the studies of the future toric lenses, we should have and exclude those, and also to add the intraoperative OCT as a confirmation that there is better contact, and then we follow up those patients. So I was thinking this would be a good way to look at it, sir.
Okay, this brings me to a second point. I think you're right in this regard that you have to, you have to use your method, which I, congratulate you to put the intraoperative OTC to measure this. I think this is not done worldwide on a broad basis, because you have to have that intraoperative OCT, and that's of course important. Now, your thesis is talking about Indian Asian eyes, and as we travel all around the world, we see that in Asia you have a lot of myopic patients. And I would start this series a little bit talking about the chapter number 9. First of all, what is your view on patients who come to the office when they're 50 years, have a high myopia of 8 diopters, and want to be spectacle independent?
Thank you for the question, sir. So I really explain all the different options to the patient, sir. I mean, this is how we normally do in our hospital, that everything from monofocal to torics to trifocals to EDOF. But after explaining, what we do is we make the patients to undergo all the investigations, and we see for if they are suitable for a trifocal or a diffractive IOL first, sir. So if they are one of those candidates that the retina is perfect, the cornea is perfect, no hyoid aberrations, everything is very pristine eyes, then we will give the option of a trifocal if the patient is interested. But if it is non-pristine eyes, definitely we give an option. Either we go with a monofocal or enhanced monofocal, or now some of the non-diffractive EDOFs also do really well, a little more forgiving. And in these cases, if you're going with toric, definitely I would say CTR, I would do implant, because again, the bag being a little larger, there is a chance of the lens rotating in these cases.
So when your cousin comes and is 50 years of age and he's myopic -8, would you basically, I'm just following up, he has visual acuity of 20/20, still a very good visual acuity. Would you remove the lens, put a trifocal lens without any doubt, or are your thoughts?
I'm
talking about 50 years, assuming you have a cousin that's 50 years.
So definitely, sir, I would give the option. If the patient is interested in getting rid of glasses, he wants to be spectacle independent most of the time, I would give him the option for a trifocal, sir, if he's interested, definitely. Yes, sir.
So let me allude this a little bit in this direction. You have used PR OCT. You have used a new method. Very quickly, what is the main difference? You have said it's a higher resolution, much more higher. You can see retina better, the imaging. So first of all, the question very shortly, is this available now, or is just a device which we have for academia?
It is widely available now, sir. With the Zeiss Lumira, I think it's a 700. You can have an option where you can have an add-on intraoperative OCT into your machine, and then you can use in these kind of scenarios where you can confirm. Let's say if there was a DM detachment and you missed it, with the OCT you can clearly identify where it is, what is happening. Then you can put the air bubble, reconfirm on the table itself whether it is attached, and then send the patient down. Otherwise, normally what we do is we think we have fixed it back. Patient goes down, then we do the OCT in our OPD, and then we realize no, it's not fixed. Then we take the patient back to the OT. So this really makes it more convenient for the patient, and also it makes it more assuring for the doctor to that everything is going on good, sir. Yeah, yes, sir.
Have you seen in your patients, because your average was 60 years approximately, you had cataract patients in this group when I looked at the study. Now, and you looked at the retina image and you didn't found any change in retina thickness, and all your parameters was almost like the same as if you haven't done surgery. Now, your thoughts again, looking to a 50-year-old high myope, do you do retina imaging before surgery? Is it useful?
Please complete your question, sir, please.
Now, is it useful to use it? I want to little bit pinpoint on the high myopic patient in 50 years old.
So for all our patients, OCT is compulsory. So we always look at the macula before surgery, not the intraoperative, but what we have in the OPD, our regular OCTs, is compulsory for all patients. More important, like you mentioned, sir, in high myopes, because we can really miss certain details, and it's more easier to counsel our patients. So in terms of the intraoperative use, specifically in high myopes, I would say is again looking at the bag. I would say whether the contact is there or not by implanting the CTR and reconfirming. Now, let's say if there's not that great contact, then you can take little extra precautions, make the patient to lie down for longer, and then recheck the patient again to see if the lens is still positioned in the right axis, and then the patient can go home. Because as you know, sir, the early post-operative 1 to 2 hours is when it can actually rotate. So at that time, if you find the gap is more, then we can make them to stay for a little longer and then confirm in 1 hour or 2 hours and then go ahead, sir.
So my last question, because I also want to be in time, but basically I want to concentrate on the issue, again, 50 years old. You have in Asia a lot of myopic patients. Now, in my department, I chair this department for 12 years now, we see an increase in retinal detachment in high myopic patients because they have done refractive lens exchange or lens exchange. Don't you think there is another good option for these patients? Because I know that there is a good option. And 50 years of age, what is your thought about this?
Please do not answer the question. Sorry. Professor Koenen, you cannot hear me because our sound system is not connected to the online system, so only it's connected to the microphone of the opponent. But we have to stop because we have more opponents, and I don't give an opportunity.
Good. Thank you.
Sorry to interrupt you. Okay, we have to continue.
Thank you.
And we continue with Dr. Ruijs. He is involved with the Department of Ophthalmology at the Amphimia Hospital in Breda, and I'd like to thank him also that he joins this morning, and I'd like to give him the word.
Thank you very much. Dear candidate, thank you for your excellent thesis. It's a very, you encompass almost everything within cataract refractive surgery, congratulate on that. I would like to ask a question on chapter 4. Yes. And in chapter 4, you assess the effect of spherical aberrations on visual acuity at different amounts of defocus with the implementation of an extended depth of focus lens, the Vivity, and an enhanced monofocal lens, the iHands. And you assess that with the visual adaptive optics simulator from Pablo Artal. Yes. You first determined the optimal value of induced spherical aberration, and you found that inducing some spherical aberration improved visual acuity at intermediate and near to some extent, although clinically probably not significantly. I have a couple of questions regarding this chapter. In the tables 1 through 4 in this chapter, you identify several statistically significant differences between visual acuities with and without spherical aberration at various defocus levels. Given the multiple comparisons performed, did you consider using a Bonferroni correction for multiple testing? And if not, could you elaborate on your rationale not to do that?
I'm sorry, sir. I didn't hear the last part.
Did you think of using Bonferroni correction because of multiple testing for p-values?
Thank you for the question, highly esteemed opponent, sir. I'm not very sure I understood the last part, sir, in terms of the correction. But what we did was we did use the spherical aberration to alter this in the steps of 0.01 microns. And we did find statistically improvement, but like you mentioned, sir, that clinically it wasn't to a great extent. Yes.
Well, the question is, if you have a p-value of 0.05 and you do 20 tests,
right,
probably one test will be statistically significantly different.
Yes.
In your research, you did multiple testing.
Yes.
So by chance, one of those tests will be...
No, definitely, sir. Like we need to do a larger sample and more, I would say, repeat the same study with a larger sample, and then we should have much better results and more reliable results too, definitely.
Thank you. And another question on that you said is that you changed the spherical aberration in 0.01 microns steps. In the methods, you described that you went from minus 0.1 to 0.1 microns. But in the results section, you state that with the patients in 50 group, the induced spherical aberration ranged up to minus 0.15.
Yeah.
15 micrometers. I'm probably a bit lost at what you meant.
So the thing is that like these EDOFs or iHands or enhanced monofocal lenses, they are already using the technology of spherical aberration to improve the intermediate. So they are almost close to being optimized. So that's why if you look at the previous study where we looked at presbyopic eyes, the steps were much bigger. But here it's smaller because these are all very small difference. We need to, it's basically just to test, because these lenses are made for the whole, the population, doesn't matter which country you're from or how your pupil size is, it's really different. So we wanted to see in Indian eyes, does it still have a potential to improve the near, just push it a little more so that you have some amount of, better intermediate and near without compromising the distance. That is the whole aim of it, because in Indian eyes, we have a little more smaller pupils than the rest of the, population. So we that's what we were looking at, sir.
And with regard to the lenses themselves, the Vivity and iHands, if I understand correctly, they use a different amount of spherical aberration to correct in the eye. Yet you find that there's no difference in the mean, even in the median amount of spherical aberration that you measured with the instrument.
Yes.
Can you elaborate on that finding? Two different lenses with different amounts of spherical aberrations,
yes.
Yet you find in the eyes the same amount?
So I think, sir, basically now how iHands has, it has a different technology where the power greatly changes from periphery to center. But again, sir, that each of these lenses have already used some amount of spherical aberration to improve their to reach that target. Even though it's not the primary way of correcting the near and intermediate in these lenses, but that is one of the subcomponents which they've used to improve the vision. So that's why the change, because both the lenses are already optimized in terms of the spherical aberration, so that almost similar kind of a spherical aberration being induced is similar, which is about 0.05. Yes.
Okay. One time for one more question. Yes, and although the differences are small, you do find a difference between the extended depth of focus lens, the Vivity, and the enhanced monofocal, the IHANS.
Yes.
In terms of that, the Vivity gives you a bit slightly better near vision without compromising distance vision. And how do you think these findings might translate to patients with significant high order aberrations due to irregular corneal profiles? Would one IOL be preferable over the other one in such cases?
Definitely, sir. I think in terms of the preference, if there's high order aberrations, we go with the. I would even go one step further, go with the monofocal and keep it simple, or we regularize it and then do it. But otherwise, if you give me a choice between these two IOLs, I would go with the enhanced monofocal, sir. And if we look at the two profiles, which is an EDOF, a non-diffractive EDOF in a VVT, and this one is a enhanced monofocal. Here, the whole point is the design is in such a way that they rely a little more weightage for the SA as compared to the EDOF, because it already has a technology in the center where it bends the light and focuses. And so it's the reliability on the SA is a little more lesser. So that's why we had a little more, I would say, to a small extent where we could further improve it by using the SA in VVT groups.
But wouldn't you rather use a Vivity lens in these eyes, because your data shows that you do get some, with increased spherical aberration, you do get some improved near vision and intermediate vision, while not reducing your far vision, and you do lose far vision with the enhanced monofocal. So I would assume it would, in these irregular corneas, or somewhat irregular corneas, you would choose a Vivity lens.
Yes, I think at the end of it, it's definitely a surgeon's preference which one they want to go for. But what normally we do here is we see which is the lens which has the least amount of disturbance in contrast and the quality of vision. But when we compare the VVT and IHANS, the IHANS has less impact on the contrast and overall quality as compared to the VVT. So that's why, because if there's a high order aberrations, we don't want to add further compromise in the quality, because it's already compromised from the cornea aspect. So that's why we want to keep it as less. I'm like you said, sir, like I was saying, sir, that I would prefer to go with the monofocal, in fact, so that there's absolutely no compromise, as less as possible. The patient already has a good contrast. At least there's no disturbance coming from the IOLs.
Okay. Thank you very much. I'd like to give the word back to the director.
Thank you very much. The opposition will now be swiftly continued by Professor van Zandvoort. He was a member of the assessment committee, and he is appointed as professor in biophysics of microscopy at our university, and I'd like to give him the word.
Yes, thank you. First of all, I would like to congratulate you and your team of supervisors with a very nice thesis. I really enjoyed also reading the introduction, even was very insightful. I have, first of all, a general question. So you state in the title and a lot during the chapters that this is specifically about Asian Indian eyes. And that raises for me, as a non-eye surgery person, the question, do you expect any differences in non-Asian Indian eyes?
Yes, sir. So actually that very, very nice question, sir. I would say why this particular Asian Indian eyes was added was because some of the studies were looking at spherical aberrations and other aspects too. And in Indian eyes, we have a little smaller pupil, we have darker eyes. So because of the pupil being small, sometimes the results might be different in different eyes or different population. So just to have that particular aspect, I added those lines. Yes.
And do you expect that to have consequences for
Definitely, sir. There is a
outcomes?
change. Definitely, sir. There is a chance because most of these lenses, I mean, at least some of the lenses are pupil dependent, and it can change results on what we have had and we have in a different country or a different population. We can have a little. It'll not be a very significant one, but there can be differences.
And can you give an example of such a difference so that the surgeons here know?
Yes. So
where
for
they have to
instance,
be careful?
now if we look at a simple example is a technique by Dr. Agarwal. So what he does is basically there's a hole in the eye which is there in the center of the pupil. So what he does is a lot of traumatic cases or anything that is very irregular on the cornea, what he does is he makes the pupil really small. It's almost like a pinpoint pupil. And surprisingly, the patient's almost 6'6" without a toric lenses. And I mean, it has its own disadvantages, but it just shows that the pupil being very small is just like how we do the optometrist does a pinhole, and then the patient immediately improves the vision without any refraction. So that is how it really stands out, and more so in let's say a diffractive IOL. When we use a diffractive IOL, if the pupil is larger, we have more higher aberrations, and all the aberrations just props up. As it becomes smaller, like in the example which I mentioned earlier, sir, that it negates all that, and so you see really well, sir.
Okay.
Yes.
Thank you.
Thank you, sir.
I also have a question about chapter 9, page 145. There's a table,
Yes, sir.
and with table 2, and which do you state later that there is no significant difference between, for example, operated and non-operated
Yes.
people after 1 month,
Yes.
month after you take them up in study. But then I look at the numbers and I see quite large differences. For example, I see here 16.5 plus or minus 0.3 and
Right.
13.1,
Yes.
0.02.
Yes.
So that seems to be significant.
Yes. So the thing is, sir, now if we look, just to make it very simple in the presentation, I didn't go into details of this particular paper, sir, but what we actually saw was the retina volume and the phase retardation from the polarized sensitive OCT. There was a change on post-op day 1, and it came back to its preoperative level at 1 month. But when we looked at statistically, we didn't find the difference. So that's why, the final result wasn't statistically significant. So we didn't want to say that there was a difference. That's also.
I'm not sure I quite understand this. Yes. So after 1 day?
So the thing is, sir, if we see the trend of the numbers, there was a drop or a change in the volume, retinal volume, on post-op day 1, sir. And at 1 month later, it came to the preoperative levels. So, but this was more of a trend, it was what was changing. But when we statistically calculated the values, whether it made a statistically significance, it didn't show up as significant. So we didn't mention that. Yes.
But that's not what I see in the table, for example. In the table, right. I see that it even goes up a little bit.
Okay.
After surgery, and then after 1 month, it's
Yes.
still significantly higher.
Right. Yes. Yeah.
So I don't understand that conclusion then.
Right.
And that's quite significant all over the table.
Right.
So do you have a possible explanation for that, or?
Not really, sir. I mean, the overall results, what we saw was not significant. That's what we.
Yeah.
Yes. That's
Okay.
it, yeah.
Is there time for another question? A short one?
No. I'm sorry.
Microscopy.
Yes. I'm sorry. We still have to continue with 2 opponents, and I would like to give the word to Professor Luiten. He is chair of the Department of Ophthalmology at the Leiden University Medical Center. Welcome, and I'd like to give you swiftly the word.
Thank you very much. Congratulations, Mr. Candidate, for this very nice piece of research. I think it's really frontline research which brings ophthalmology to a next level.
Thank you, sir.
So thank you very much for that. I enjoyed very much reading this.
Thank you, sir.
So I first start with a more practical question, because you in chapter 8 you mentioned and you encourage the surgeons to put the intraocular lens in a vertical direction. And I see a lot of patients with this dysphotopsia, and I always put the lens in a horizontal way. So how do you weight the difference between creating dysphotopsia and the stability of the intraocular lens? What would be your advice?
Yes, thank you so much for the question, highly esteemed opponent, sir. In our regular practice too, we also do implant in the horizontal position because it's more natural. We sit on the temporal side, we place the lens, clean the lens, and we close it. But even so, sir, even though it is horizontal, we see a large chunk of patients, even though it's horizontally placed, we still see dysphotopsia. So because of that, and there are many ways that some surgeons which do, sometimes they laser the rexus so the lens comes a little up, or sometimes they implant a lens on the top. There are different ways to avoid it, sir, but currently, since we are seeing a lot of patients, even though we have oriented the haptic-optic junction horizontally, we still see dysphotopsia. But definitely, this is something that we need to look at, sir, and see, does it really make how much of a difference from vertical to horizontal in terms of visual quality, in terms of rotation, in terms of stability, everything we need to look at it, sir. Definitely, sir.
Okay, thank you very much.
Thank you.
So I will continue on chapter 5, which I think is a really interesting paper on cylindric defocus.
Yes, sir.
I've always learned from my teachers that it is very important for especially older people that they have a little of astigmatism, because that helps them with reading capacity. So in your introduction, you said you have to correct astigmatism of more than 0.5 diopters, and then in chapter 5 you're introducing cylindric defocus.
Yes.
So what is your idea about that?
Yes, sir. Thank you for the question, sir. So basically now we cataract surgeons, we are so used to, when we think about monovision, sir, we always think about using spherical power. It's been in our head, and that's what we've been using over the years. But I think more so maybe we can think about even inducing cylindrical power too. In the sense that maybe these premium lenses, be it a trifocal or EDAF, they already have a toric version, and then we have to align it. Even though patient does not have power on the cornea, we use these lenses in a particular position so that it induces some amount of cylindrical defocus. Basically, if you look at the papers of what we have done is we have converted the eye more with the rule. Majority of them did improve with the rule. And now what is currently going on is we are seeing it's not that 100% of the patients improved with the rule. Some of the patients also improved in a different axis. So we were thinking that how we are currently collecting preoperative data to predict which are the patients which will improve at what axis, so that we can predict it, and then maybe in the future designing of the lenses, we can align it in that axis or induce some amount of cylinder so that they have better near and intermediate vision.
So what would be your advice for the general practitioner, the ophthalmologist, when they do surgery on a patient with an against the rule astigmatism or with the rule astigmatism? And what do you want to, as a result, do you want to have residual against the rule or with the rule astigmatism?
Preferably with the rule would be better to leave the eyes, a little bit of with the rule. But it's not that all cases improve with that. So that's what we have realized. But even though it's a majority of the cases, so now we have to do a customization to the next level to see how we can predict the axis of this cylinder or how much cylindrical power we have to leave by looking at the preoperative data of the cornea.
And so how would you do that? How to predict that?
So what we're trying to do is we're looking at all aspects from assays to how the K values are. We are taking all the information of the preoperative eye, what the scans were taken, sir. And then we can test it post-operatively, like how we tested post-operatively, which cylinder improves for these patients. So then what we can do is link the two. We put this into AI and show that, okay, this is the preoperative data. Such a patient, if you have a preoperatively, they will improve at this particular axis. This is the amount of cylinder induced, they'll do well. So that we need to, that we are at it, sir. We are adding all that data up and piling up for the AI so that then preoperatively itself we can predict which is the axis, sir.
Oh, thank you very much.
Thank you, sir.
Do I have time for a small last question?
Yes, you have.
So I have a burning question for myself because I don't understand this problem. Because is there any relationship between the shape of the cornea and the spherical aberrations? Do you have an explanation, or can you explain me what is this?
So definitely, sir. So I think so the amount of normally the spherical aberration in this the eyes is about plus 0.27, sorry. And what we are currently not doing, I think it's a very important aspect which you brought out, sir, is even though the companies can actually do something to or give lenses or improve the vision much better by looking at the spherical aspect and then giving a lens. Because right now all these presbyopic lenses like we were discussing have spherical aberration. And but preoperative, what is the spherical aberration of the cornea is not being added anywhere. And that is something that, to do that customized or give even better results, that addition of the preoperative level and then what lens you're implanting, what is the addition and what is the outcome, and then...
Can you explain me, is there any relationship between a prolate or oblate cornea with the spherical aberrations?
Oh, yes. I think so. What happens is... to tell you the truth, I don't remember that particular answer, sir, but I would say is it does differ because no, I'm not sure, sir, about this answer. Yes.
I find that also a difficult question, so I will give the word back to the director.
Excuse
Thank
me,
you very
yes,
much.
Yeah.
Then the opposition will be closed by Dr. Berenschot. He is affiliated with the Department of Ophthalmology at our university, and I'd like to give him also the opportunity to discuss.
Okay, thank you, Prorector. I first of all want to congratulate you with this thesis and also the promotion theme with this thesis and your very nice introduction. Many chapters have been discussed, but chapter 3 is still open, so that's I want to ask some questions. And first of all, I want to look at the table 1 and table 2 in this chapter. And well, in contrast to what the statistical question where we found differences which are not significant, here I see values 0.15 for two presbyopic and diabetic eyes with the same standard deviation, but still a p-value of 0.03. Well, that's something to be explained to me because that I don't understand this at all. Can you elaborate on that, please?
Yes. So, so what we did in this particular study was, thank you for the question, highly esteemed opponent, sir. So, I would say is, so in this particular study, what we did find was that even the uncorrected vision itself of the preoperative, the uncorrected vision for the distance, even though it's similar between the two groups, the normal and the diabetic, the near vision was significantly better.
No, but let's first focus on the delta SA, which has similar values, but and a similar standard deviation. So in my opinion, they would be similar, but it says here a p-value of 0.03. So how can this be significantly different when the values are exactly the same? That's strange, isn't it? Maybe you can, look at page 47, please. And then table 2, the final rows. So the values are exactly the same in the two columns, but there's a p-value which is very significant. Well, this is something I don't understand.
Definitely, I have to look into the calculation again, sir. But we did repeat the stats twice, and we did find the same p-value. But I can look at the values again, sir. Definitely.
It would be nice to discuss afterwards,
definitely,
maybe in depth.
Yeah, yes.
Well, continuing on this, then we see that in the diabetes, as you wanted to explain, maybe yourself as well, have a better visual acuity. Well, in my opinion, diabetes, that's increased aging. So if you age, then in general everything deteriorates, including visual acuity. Still, you find a better visual acuity in this diabetic age, so that's a little strange. On the other hand, I see the higher order aberrations, they are a little bit higher in the diabetes. Could it be that you also need higher order aberrations to increase visual acuity? And maybe a related question is this higher order aberrations, at what distance were they actually measured?
I think this is a very important question which we've been investigating into, sir, because it's very, like you said, sir, that in a diabetic eye, usually what happens is the trend of the cataract setting in or the hardness should be much, and technically it should be worse than the normal presbyopic eyes. But surprisingly, we have found the other way, and that is something that we are actually looking into. We're looking at how the axis of the cylinder, even though that statistically there's no significant difference in the distance vision, but we're looking at the quantity of the amount of cylinder, the axis, the essays, high order aberrations. We're just trying to find some kind of correlation which is causing this kind of a better vision in these eyes. Yeah.
But do you have some ideas where to look at?
No, sir. That's what we are looking at as of now. I mean, once we have the results, definitely I can share, sir. Yeah.
Okay, well.
But there is a possibility that the cylindrical, I'm thinking, sir, I'm not sure. But once we have the results with us, we'll have a better idea. But there is a chance that some amount of cylindrical change is happening in these diabetic eyes and group, because of which it might be improving, having better near vision.
And the higher order aberrations, could that be?
That is also a possibility, sir. But like in the other experiment also, sir, if you saw that by inducing some amount of cylindrical power, the distance did not drop too much as compared to a regular spherical power. So there is here also it could be one of the aspects why they might be seeing better, just because of the axis of the cylinder, what they have. Yes.
Okay. Well, thanks a lot for your question. So then I have maybe a more general question comprising the thesis as a whole. This is all about visual acuity,
yes,
which you compare in different lenses and different groups. But in daily life, I don't think visual acuity that's that important. I mean, contrast sensitivity, in my opinion, would be a better way to discriminate. If you look at contrast sensitivity, would that change your results? Would you need maybe more or less circular aberrations or cylindrical power?
Yes, I think absolutely true. So I think that can be one of the angles which we can look at, because why we stuck to this itself is very taxing for the patient. The investigation we were doing, because they get very tired and it's a long term, one eye at different distances, so many scans, so they become very.
Mr. Candidate, you are allowed to finish your answer, but you don't have to. It's your choice.
So, thank you. So basically, because it's so taxing, we didn't want to add more and more tests. We thought we'll do it as a separate test, and definitely contrast is the need of the hour, because we need to look at how it changes the quality of vision too. Definitely, sir.
Thank you.
Thank you very much. Mr. Shetty, Mr. Candidate, the time appointed for defending your thesis has now passed. The degree committee here present will now withdraw and to discuss not so much the quality that has been approved, but particularly the way you have defended your thesis this morning. I request that you and your company in this audience here await the results of all the deliberations and our return to the aula. Thank you very much.
Thank you, sir. Thank you.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if it's questions that you've got, go the extra mile and that. read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Get the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. To the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goal's only getting clearer. East side to the west side, no place like home. If it's questions that you've got, go the extra mile and die. What's on the line? I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Dear Mr. Shetty, the degree committee here present has assessed the quality of your thesis, but in particular the way you have defended your thesis this morning. And in view of its positive verdict and taking into account your previous qualifications, the degree committee has decided officially to grant you the degree of doctor. Compliments. Professor Nuits is authorized to confer upon you these academic distinctions in accordance with Dutch university custom. And therefore, I invite your supervisor now to take the floor.
Please all rise.
Do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promise, sir.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Naren Shetty, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee and affixed with the official seal of the university.
Thank you.
The photographers you can proceed forward. Don't hesitate. Yes? Please, yes. Over there. Laudatie will be given by Professor Nuits.
Dear Dr. Naren, it gives me great pleasure to address you first after achieving your doctoral degree. I had already some experience of working with PhD students with the name Shetty, as I also had the honor of guiding Rohit, who defended his thesis here in the same room successfully in 2015. So I could have known that the process of completing a PhD in the Shetty family usually goes at an amazing speed. In 2022, I received a request to be your guide for your PhD course, and in a short time frame, your dissertation resulted in 8 good papers, for the majority published in the peer-reviewed literature. In your research, you have been using diagnostic innovations like visual adaptive optic simulations in an experimental setting to explore what the effect of optical aberrations are on the visual quality of patients after implantation of EDOF and enhanced monofocal IOLs. These outcomes will help us in deciding which type of IOL is most suitable for a particular patient, and I believe is an excellent example of personalized medicine in cataract surgery. What is the secret recipe for such an achievement in this short time frame? Those of us who have visited your institute are impressed by the easy access you have to the most advanced technological diagnostic tools, like the polarization-sensitive OCT that you used in your thesis and that is being used in your lab and also in your clinic. Another factor in this success story certainly is the quality of the Narayana Netralaya research team under the guidance of Rohit and Abhijit, which consists of highly motivated and dedicated people. NN, as you call it, now has been transformed into one of the leading research institutes in ophthalmology in India. You and the institute need to be congratulated in being able to provide excellent ophthalmic subspecialty services and at the same time deliver community eye care at no cost to the financially underprivileged. That, of course, was the ultimate goal of your father, the late Dr. Bhujang Shetty. And I'm convinced your father is immensely proud of your achievement today, as is your mother, Mrs. Raikamal Shetty. At the University Eye Clinic of the Maastricht UMC, we are particularly proud that we could contribute to this PhD dissertation resulting from the Maastricht-India Strategic Alliance. And today, we already have seen the successful defense of the 9th PhD thesis of a candidate from your institute. For the future, we are delighted to continue this prosperous strategic cooperation in ophthalmic research between Bangalore and Maastricht. And this will be formalized this year with the appointment of Rohit as a visiting professor at the Maastricht UMC. Dear Naren, it has been a great pleasure to work together with you on your thesis over the past 2 years. I was impressed by the efficiency in managing the course of your PhD project by primarily using WhatsApp. For a representative of the somewhat older generation, I must say I had to get used to that communication pattern. Even your introductory talk and video came by WhatsApp, not by mail. So I also would like to thank you warm-heartedly for your generous hospitality during my visits to Bangalore over the years. I would like to pass on the congratulations of myself, of Carol Webers as head of the department and the whole University Eye Clinic to you, your wife Namrata, your family and your staff on this magnificent achievement. And then in these moments of happiness, I believe it's appropriate to finish with a saying from a spiritual book that was written by your father, entitled The Power of Love, which said, we all seek happiness by receiving, but true happiness lies not in receiving, but in giving. And I think you're a perfect example of that. So thank you, and congratulations once again. I would like to give the word back to the rector.
Dear Dr. Shetty, let me address you now with your new official title, and I think you should be very proud of this. It's the high academic distinction which you can receive in the Netherlands, and you really awarded it with prestigious. I also would like to congratulate you on behalf of Maastricht University, of our board of directors. And in my congratulation, of course, there will be also your two promoters, Dr. Roy and Professor Nuits, who guided you over the last, I think, 2.5, 3 years to get to this point today. Very nice compliments. I also would like to thank the members of the Corona who joined today and who had an inspiring discussion with you. There were some questions were maybe a little bit more tough than other questions, but you gave all the answers rather correctly. I would like also, in my congratulation, go to your family who is sitting right over here, who came all the way from India to join today. Thank you very much, and your candidate did a good job. And how are we going to proceed? Now, first of all, I'm going to officially close the ceremony. And for closing the ceremony, I'm using my hammer, which you haven't seen, but I have it right here. And this ceremony is now officially closed. How do we proceed? We will have a reception in the rafter, and the audience and the family can already go over there. We will make one picture here in the audience, together with Professor Konen, who is still available, and we make a picture on the stairs of our university. And after that, we will join you in the reception room, and there's time for celebration. Thank you very much.
Thank you.